There's a supposed to be. Was it the one?
Oh.
I know. That was on purpose.
This wasn't my brother.
Sorry, instruction cards.
That's good.
That's all it's been. Oh, I saw. Hello.
I have the pleasure of introducing Rick Vavolizza for his Chief Grand Rounds. Rick was born and raised in Rye Brook, New York. He completed his undergraduate education at UNC Chapel Hill, where he studied nutritional biochemistry. Prior to medical school, Rick was a full-time 7th grade biology teacher, where he discovered his passion for teaching. He then attended UVA for medical school and is now a chief general surgery resident at UVA. During his research time here, he focused on opioid reduction protocols, breast cancer research, as well as a phase 1 and phase 2 clinical trial using a melanoma vaccine plus pembrolizumab in patients with advanced cancer. Rick's passion for teaching students and junior residents is ever present, and he has received numerous teaching awards at both the local and national level, including being this year's recipient of the American College of Surgeons Exemplary Teaching Award. Outside of taking care of patients, Rick loves playing squash, skiing, and spending quality time with his close-knit family, including his parents, Tammy and Bob, who are here with us today. Next year, Rick will be completing a fellowship in breast surgical oncology at MD Anderson Cancer Center. I have gotten to know Rick over the last 6 years. His dedication to teaching medical students and residents is truly remarkable, deeply impactful, and to be emulated. I am lucky to call him a friend, co-fellow, and future colleague. Please join me in welcoming Dr. Vavolizza for his Chief Grand Rounds titled The Art of Effective Teaching, Inspiring, Engaging, and Empowering Learners.
Thank you so much for that really kind introduction. I'm really excited to be able to present my Chief Grand Rounds today. You know, I was flying back into town this past Sunday, and this lady sitting next to me on the plane asked me how long I've been living in Charlottesville for. And it finally dawned on me that it's now been 10 years since I moved here. I was only 23 years old at the time, eager and excited to start medical school at UVA. And 10 years later, I feel just as passionate about medicine as I ever did. And I also feel confident in taking care of sick patients inside and outside the OR. And this came about because of effective teachers in my life. My Chief Grand Rounds topic is something I'm very passionate about. My goal today, however, is not to provide a history lesson about the first teacher in the United States or to discuss the latest research statistics in education, but to rather share with you personal experiences of what I've learned along the way for what works, and most importantly, a framework by which we can all teach, inspire, and empower learners from medical students all the way to chief residents. I hope you take away something from this talk that is tangible and something you can implement on a daily basis starting today. Let's get to it. I have no financial disclosures to report, and I'm also not an expert in this matter, but I am incredibly passionate about it. Think back to one of your favorite teachers. What did you love about them? Why do you remember them still today so fondly? Was it their inspiration, like Miss Frizzle on the Magic School Bus? Their investment in you? Their passion for the subject matter or the way they explained things that made you love it? Or maybe it was their patience and kindness in creating a positive environment, one that allowed you to ask questions when you didn't fully grasp the concepts. A teacher is more than just a lecturer or someone that imparts knowledge. A teacher is someone who inspires and engages and then empowers others to achieve greater heights through that knowledge. And the way that that knowledge is conveyed will impact how well it is remembered, how well it is applied, and even retaught. I bet many of us in this room went into our subspecialty in part by mentors we cherished in that specialty. Mentors that explained things well that we thought, hey, I'm pretty good at this. How amazing of an opportunity we have that each of us have in this room to be that next exemplary teacher and that next role model to impact the next generation of doctors and how they think of a disease process, or even be the reason why someone chooses to go into your surgical subspecialty. A great quote by Nelson Mandela states that education is the most powerful weapon which you can use to change the world. Today, I look forward to discussing my journey in becoming a teacher and why I became so passionate about teaching. Teaching medical students and residents didactic information, teaching patients, and then teaching what's in it for me. Our past experiences greatly shape the way we think and what we find passion in, and this is undoubtedly true for me. Growing up, learning did not always come easy to me. I always loved math and science. That was easy. But growing up, I really struggled in the humanities, with reading, and even with summarizing important information when creating study guides. In elementary school and middle school, I was very curious and excited to learn, but I often came home not having absorbed much at all. In fact, the week prior to tests, my mom was kind enough to sit down at the kitchen table with me for hours and hours each night and create study guides with me, where she oftentimes retaught me what was already taught in class. I was so motivated to learn. I just needed to be taught how to learn. And that's exactly what my mom did for me. She taught me how to break down complex topics into digestible parts and how to create study guides to put it all together. This took several years. But once I started high school, I was fine and did quite well. Where I am today, though, I greatly owe to both of my parents because they never gave up on me at an early age. From these experiences, I found a calling and that I wanted to help others who struggled to learn in the beginning. Starting in high school, I became a private tutor and started tutoring math, science, Spanish, which then progressed into tutoring AP courses and SAT tests. Through word of mouth, I soon became pretty much booked around the clock, multiple students every single evening and even every weekend. But the success of these children became so noticeable that I even started tutoring across multiple school districts. But what was most rewarding was then seeing struggling students become confident and not only attaining higher grades, but also seeing that the way of thinking and studying had changed and that they started applying it to all aspects of school, just as I was taught when I was struggling. As mentioned, reading was also very difficult to me and something I also had to overcome over many years. I even completed a program called Learning RX, where they bring you back to the basics of phonemes and word chunking to reteach you the basics of reading to optimize comprehension. Once I got to college, this previous struggle motivated me to create a literacy program that targeted the Hispanic community in Chapel Hill. The program mimicked Hooked on Phonics, where we had our members record books on tape. We packaged those tape recorders and books in drawstring bags, and then donated them to a Head Start program that children could check them out and return them over the next week in order to be exposed to hundreds of books over the course of the year. I learned a lot from these experiences. I learned the importance of self-reflecting and identifying a weakness, but most importantly, to then get up and do something about it, because that's the only way that you can improve and move forward. At this time, I wanted to take my passion for teaching full circle. Prior to medical school, I actually became a 7th grade biology teacher at this predominantly Hispanic middle school in Westchester, where I got to teach both students in English and in Spanish. And this was an incredible year. They allowed me to redesign the curriculum where I emphasized human metabolism and diseases that were tangible and frequently encountered by these students. Rather than focusing excessively on the net ATP produced in a cell, I really wanted to focus on exciting these students about science. That's what they needed. They also didn't give me much of a budget, but I used some of my own money and purchased frogs to incorporate dissections during our GI unit. We hatched chick eggs during our embryology unit, and it was amazing to see how previously withdrawn students became engaged and how they started asking such thought-provoking questions. It soon became a little zoo in my room. You know, I thought I was becoming almost the Miss Frizzle of the middle school. I eventually had to give the chicks away as one morning I came in and two of them were out of their cage, roaming around and, you know, bobbing their heads. And I was like, oh, geez. But and then when the kids came in, you know, they said, Mr. Rick, which is what they always called me. They said, Mr. Rick, where are the chicks? And I looked down, I said, KFC. They said, Mr. Rick. But I loved these students, and I learned so much from them. They really taught me, I think, how to systematically break down difficult concepts into simple, digestible parts. And this is something I carry with me still today when working one-on-one with medical students, and especially when educating patients in clinic. So, teaching medical students and residents didactic information. When working with medical students, I love using a pen and blank sheet of paper, whereby together we break down each disease process from breast cancer to colon cancer to gallbladder pathologies into 5 digestible sections: risk factors, presenting symptoms, diagnostic workup, treatment, and surveillance. By understanding what I call the 5 pillars, I believe you can comprehensively understand any disease process and manage it from start to finish. Let's first take something quite simple. When a patient is diagnosed with a DVT or even a PE, most students and residents will say, well, you put them on therapeutic Lovenox or Apixaban. But for how long? Should you repeat an ultrasound or even a CT scan to ensure it's gone? When do you consider TPA versus catheter-directed thrombolysis versus an IVC filter? Again, I think it isn't until we understand all 5 pillars, including surveillance or the aftercare, do we really comprehensively understand a disease process and can help someone. So let me give you 2 examples using the 5 pillars. The first I'm going to use is melanoma, and this is how I always write them out with students. The risk factors include sun exposure, fair skin, and family history. Presenting symptoms are the ABCDs of melanoma. A for asymmetry, B for borders irregular, C for color variation, D is for diameter greater than or equal to 6 millimeters, and E is for evolving over time or elevation. Diagnostic workup, if the size is greater than or equal to 2 centimeters or in a cosmetic location, you do a punch biopsy. If it's less than 2, you can consider doing an excisional biopsy. The treatment involves a wide local excision plus or minus a sentinel lymph node biopsy. The wide local excision margin is dependent on the Breslow depth from your punch biopsy, such that the Breslow depth in millimeters is equal to your wide local excision margin in centimeters. If the Breslow depth is less than 1 millimeter, you do a 1 centimeter margin for your wide local excision. If it's between 1 and 2 millimeters deep, you do a 1 to 2 centimeter margin. If it is greater than or equal to 2 millimeters deep, you only do a 2 centimeter margin, as taking a larger margin at this point does not help to further reduce your risk of local recurrence. Now you have to ask yourself, okay, so when do you do a sentinel lymph node biopsy? This is done when the depth is greater than or equal to 1 millimeter or greater than or equal to 8 millimeters with ulceration. So then when do you do a complete lymph node dissection? Well, that's done when you have clinically positive lymph nodes, meaning palpable or seen on imaging. And when do you get preoperative staging studies via CT and brain MRI? And that's when the Breslow depth is deep, or greater than or equal to 4 millimeters or 2 with ulceration, or when you have clinically involved lymph nodes. And then what if the sentinel lymph node biopsy is positive? Then what do? We used to always do a complete lymph node dissection. However, now we do ultrasound surveillance of the lymph node basin based off the MSLT-1/2 trials. And lastly, who gets adjuvant immunotherapy? And these are for patients with a positive sentinel lymph node. There's dabrafenib for patients with BRAF positive mutation, and of course, ipi/nivo for the majority of our patients. By presenting information using this framework of the 5 pillars, risk factors, symptoms, diagnostic workup, treatment, and surveillance, allows one to comprehensively understand and manage a disease process from start to finish. So much of the time, we focus just on treatment in that table, but it really needs to be the comprehensive understanding. In fact, students frequently ask me, do you mind if I keep this? The other way we can still discuss, you can still discuss the 5 pillars is through a case or case-based learning. For this example, I'll use the topic of breast cancer. Again, this is exactly how I write it out every time for medical students on my team. So let's say a 40-year-old female with no family history or risk factors for breast cancer, including normal estrogen exposure, presents with a screening detected abnormality on her first mammogram, since you start screening at 40 Q1 years, or even presents with a self-detected palpable mass. You start your diagnostic workup by obtaining a diagnostic mammogram and plus or minus an ultrasound correlate. The radiologist in your case study reads it as BI-RADS 4, and you remember that 4 means a core. So you continue your diagnostic workup via core needle biopsy and an axillary ultrasound. In this case scenario, let's say that the core needle biopsy shows invasive ductal carcinoma. It's grade 3, ER negative, PR negative, and HER2 negative. So triple negative breast cancer that's 3 centimeters in size. At this point, many students and even residents' heads start spinning. But I like to explain that the treatment can easily be broken down into 3 categories: surgical oncology, medical oncology, and radiation oncology, as these are the 3 specialties a patient with breast cancer will see. For surgical oncology, you tell your patient that she has 2 options, either a mastectomy and sentinel lymph node biopsy, or a lumpectomy plus radiation, as radiation always comes with a lumpectomy, and sentinel lymph node biopsy. Noting that both options have equal overall survival, because otherwise there wouldn't be an option to choose from. Regarding the breast, you must then ask yourself, are there any times when you have to do a mastectomy? And yes, and that's when there's bad tumor to breast ratio. For example, removing a large tumor from a patient with a size A cup, as this would create a disfiguring crater. We only did a lumpectomy. Or you have multicentric disease. Regarding the axilla, you have to ask yourself, so who has to get a full axillary lymph node dissection? And that's for patients with greater than or equal to 3 positive sentinel lymph nodes as per the Z11 trial. And similarly, patients with clinically palpable lymph nodes used to always get an axillary lymph node dissection. However, for several years now, the standard of care is such that patients with clinically evident lymph nodes that are biopsy proven get neoadjuvant chemotherapy first to see if we can downstage them and convert them to clinically negative lymph nodes. If they don't convert, they still get an axillary lymph node dissection. However, if they do convert to clinically negative lymph nodes, meaning on exam and on imaging, they then undergo a sentinel lymph node biopsy and a targeted lymph node excision of the previously biopsied and clipped lymph node in an effort to possibly spare them the morbidity of an axillary lymph node dissection. If those are negative, then they're done. But if either of those are still positive, then they go on to get an axillary lymph node dissection. So that is the surgical management. Next is medical oncology regarding chemotherapy and endocrine therapy, where therapy is pretty much dictated by the patient's receptor status, ER, PR, and HER2 new. So who gets chemotherapy or neoadjuvant chemotherapy? All patients with triple negative breast cancer and patients with HER2 positive disease, or patients with clinically positive lymph nodes to try and downstage them, as we just discussed. So who gets endocrine therapy? This is for patients that have ER, PR positive disease, with HER2 being negative. The third doctor that your patient will see in this case scenario is a radiation oncologist. We already discussed that a lumpectomy always comes with radiation to sterilize the tumor bed. So then who gets radiation after a mastectomy? This is for patients with positive sentinel lymph node or had clinically positive lymph nodes prior to neoadjuvant chemotherapy. Their tumor size is greater than 5 centimeters, their skin involvement or PEC minor involvement, or there's persistently positive margins. And that's it. This one-page summary can allow you to treat pretty much any patient with breast cancer by, again, using the 5 pillars. We're here in breast cancer, under the header of treatment, you can further break it down into the digestible sections of surgical oncology, medical oncology, and radiation oncology treatment. At the end of these 10-minute chalk talks I do between OR cases and breaks in clinic, I found that the student or even junior resident who partakes on our team now has something tangible to take home with them to review and reference over and over again. Whether that be when seeing a patient in the attending's clinic, when seeing a new consult patient for the attending in the ED, or even when studying for boards. One's investment and how we organize and convey this information can have a powerful impact. Next is teaching patients. One of my favorite quotes and memories that's greatly influenced my teaching comes from my first patient I ever treated when I was an EMT in New York. As an EMT, you're responding to 911 calls, but also doing a decent bit of transport, such as bringing patients to their nursing home or skilled rehab center. Well, my first patient I ever transported was this sharp 62-year-old female with a British accent and a very kind soul, who unfortunately had advanced cancer and was undergoing radiation therapy. I ended up transporting her every week over the course of the next 5 weeks while she was undergoing treatment. And I vividly remember our first conversation together, riding in the back of the ambulance together. I told her that I wanted to go to medical school. And she told me, don't ever forget that an informed patient is an empowered patient. And she was spot on. How we educate our patients is a mere extension of how we educate students and residents, just not using layman's terms. We can still frame our discussion using the 5 pillars, from answering their questions about risk factors and why this happened to them, to then focusing our discussion on their diagnosis, their treatment options, and what their surveillance, if any, will look like. I think the art of teaching also makes you a better physician, especially in the eyes of the patient, by knowing how to explain each of these and how to write things out with them so they have something tangible to take home with them. And this parallels the chalk talks we just discussed. One of the many reasons why I love breast surgery is because there's also so much patient-centered education that goes into shared decision-making. This is something I really gravitate towards and hope to be effective at. I look forward to sitting down with my patient with a pen and paper in hand, explaining the diagnosis to them, outlining their surgical options, and finding one that will provide the best treatment for them, both oncologically, but also psychologically, and outlining the next steps. Because when a patient knows what is to come next, they feel more on top of their disease process. My first patient as an EMT really was spot on. An informed patient is an empowered patient, one that is destined to do better both medically and psychologically. My beliefs, however, aren't just thoughts. They're corroborated by research. In a prospective trial investigating the effect of non-adherence to adjuvant endocrine therapy on distant disease-free survival, showed that among over 1,100 premenopausal patients with breast cancer, those who were biochemically non-adherent to tamoxifen had a statistically significant shorter distant disease-free survival with a hazard ratio of 2.31 and a p-value of 0.03. Research has then showed that mitigation of psychological distress and fear of cancer recurrence, as well as improved patient-centered education, can drastically improve such adherence to adjuvant treatment regimens, even if the side effects are still present. What we do matters. How we simultaneously educate our patients so they know why they should be taking a medication, while also supporting their emotional well-being, can clearly impact their cancer outcomes. And lastly, you're probably thinking, teaching is a lot of work, so why bother? What's in it for me? I would submit that teaching is the foundation to building a powerful team. Every month when I'm paired with a new medical student and a different set of junior residents, I think of building a strong team. The better my team is, the better my patients will do. I do the exact same thing every month, every rotation. First is teaching medical students how to set up their epic. so they can pre-round efficiently on patients and in the correct order: vitals, ins and outs, results, imaging, etc. in that order. Second, it's teaching them how to present. The order in which you round in, how your tabs are set up, is the order in which you should write things down in, and thus the same order in which you should present in. I even send this exact sticky note to everyone on my team the first day of every rotation. So again, it's something tangible to reference for the order in which to present. Now, can't complain if the student's presentation on round or in clinic is out of order or taking too long, because it contains excessive information if we didn't take the time to teach them. Third is teaching them how to be prepared for clinic by showing them where to find colonoscopy reports, pathology reports, and even outside hospital records and care everywhere. Fourth is teaching how to diagnose and treat the most common diseases specific to the service that you are on by conducting chalk talks between OR cases or even after clinic with consideration of using the 5 pillars. And fifth is teaching how to apply information by teaching a topic that you frequently find students or junior residents do not understand well, and making that your priority, such that everyone who rotates with you will know after leaving your service. Over the past 6 years, in residency, I've found that the #1 topic students don't truly understand is volume status, or what I call volume down. I think the crux of inpatient medicine, I think this is the crux of inpatient medicine. You know, during their presentation, after the report, a hemoglobin drop, for example, I'll frequently ask them, do you think they're bleeding? Or when presenting ins and outs, I'll frequently ask them, why do we care about urine output? No one's measuring my urine output, for example. Oftentimes, the answer to both of these questions is, well, I'm actually not sure. In medical school, you'll learn all these fancy up and down arrows that go with changes in cardiac output and systemic vascular resistance, widening pulse pressure for various states of shock, etc. But they then don't always know how to put all the data together and apply it clinically. This chalk talk I do on volume down, many medical students have always told me that it's one of their favorites and most helpful in all of 3rd year. It's so rewarding to me to then see students now apply this knowledge on the floor and on the wards and seeing their new sense of confidence. They go from just reporting all the numbers to now stating, I'm not currently concerned about this hemoglobin drop from A to D, for example, because they're not tachycardic, they're making good urine output, etc., etc. And we can continue to monitor for now. This is a much stronger team at all levels, a team that is fully in sync to such an extent that they may start to realize that wearing khaki pants and a blue button down is the best way to dress for clinic. I'm totally kidding. But this was hilarious when we all showed up to morning rounds wearing the exact same outfit on orange. So to bring it full circle for everyone in the room, including all the attending, of course, why bother? What's in it for me? By investing time in teaching didactic information, you create a much stronger team at all levels. I really think that surgical education is not just teaching surgical skills in the OR, but so much of general surgery is all about preoperative and postoperative care. This is something I'll continue to focus heavily on as an attending, because when your team is stronger, they'll be more skilled at rounding without missing a detail or early signs of a complication. They'll be more efficient in your clinic, and ultimately they will take better care of your patients because they know more. It's pretty hard to beat those incentives. To go one step further though, this notion is not isolated only to medicine. The best Fortune 500 companies in the United States, from tech companies like Google to investment banking firms like Goldman Sachs, invest tremendously in their new employees from day one, because they too know that doing so creates high quality output. For example, almost all investment banking companies on Wall Street use a program called Training the Street, which is a short set curriculum that teaches all new employees tangible and project specific information regarding how to build in error checks to all your coding in Excel so that detail is never missed. how to systematically perform evaluation to a company, and how to execute the financial accounting involved in a merger or acquisition. Compare that to being a brand new intern in the summer, July, starting in blue, or starting in the TCB PO with your first ECMO patient. Or maybe now come December and you've never taken care of a fresh Whipple or a fresh kidney transplant. Remember, junior residents or even all residents don't know what we don't know. Set residents up for success. The more we invest in preparing our students and residents when starting a new service, the more we'll learn and the better we can serve our patients. After reading through the comments that students and residents have left me over the past 6 years, I generated a list of themes that they reported over and over again. These quote, what I termed best practices for teaching, comes directly from those that are in this room, the medical students and residents at all levels. And it is what they find important and effective. The first, and some of these might be basic, the first is show your passion for the topic. Students and us as residents thrive off of that energy and excitement and makes one more invested. Just like how Dr. Friel can somehow excite a room about discussing perianal disease at 6:30 in the morning at morning conference. The second is make learning relevant and always explain the why. By connecting information or a disease process to one's life or shared experiences, it makes that information more applicable and meaningful, and thus easier to remember. Third is actively create a positive learning environment to ask questions. I've always believed that there is no such thing as a stupid question. In fact, I tell this to every single one of my medical students on the first day. In fact, I'll even go one step further and confidently say that sometimes the most basic questions are the most important ones, as they bring forth fundamental guiding principles of surgery. Oftentimes, in medicine and surgery, we focus on such minutia that early learners actually miss the big picture. For example, almost every medical student in the room can tell us, the different ion transporters in the loop of Henle. But just as we discussed earlier, few actually know why they're even reporting urine output or how to use it to assess volume status and as a means for goal-directed fluid resuscitation. So if we actively create a positive environment where students and residents feel comfortable to ask questions, to ask what may seem like basic questions, or we can pose a very basic question to them to ensure that fundamental knowledge. Fourth is give compliments when one demonstrates progress. I know that's a little taboo in surgery. Whether that's them applying new knowledge to you two discussed the week prior, or how they now are better developing and following a plane during a dissection. This positive reinforcement is the fuel that keeps someone going, and so much in medical school and even residency can seem like an uphill battle. Fifth is perspective matters. When I look at a new medical student on my team, I consciously think to myself that I want to invest in you so that you excel in these categories in order to get you to an honors. I make it my goal to make sure he or she knows how to gather pertinent HPI in a systematic fashion, how to analyze complex data, to synthesize information, and then formulate self-driven assessments of our patients. I try not to say, well, the student really didn't do that much for us, or he wasn't very good at presenting, or she wasn't very efficient in clinic. No, I say I need to double down and invest more in them to get them to be better at X, Y, or Z. And not every student will get there, and that's okay. It is what it is. How I look at students on my team, I hope that attendings continue to look at residents. Residents, I think, all peak at different parts in their educational journey. And when someone needs that extra help, we should double down on it and focus our energy there. Sixth is find a disease topic or technical skill that you frequently find students and residents don't fully understand, and make that your priority, such that everyone who rotates with you must know after leaving your service. 7 is teach the textbook answer or the board's answer first. I would one thing that I've always said is I try and avoid saying, well, at UVA, we do it this way, or sometimes you can do it this way. I think this really confuses junior residents. Instead, focus on the textbook answer first. And once that's mastered, then you can get fancy with discussing nuances based off of new research. And lastly, 8, consider teaching didactic information using the framework of the 5 pillars for every disease process. I really believe that this framework allows for a comprehensive understanding of any disease process and proceeds in a logical, stepwise manner such that nothing is missed. It also provides a uniform approach that can be used when teaching medical students, teaching residents, including chief residents for boards, and even when educating patients in clinic. If you were to only incorporate one thing into your daily teaching, I hope this framework is it. With that, I wanted to say thank you. Thank you to my family who has supported me every step of the way. This accomplishment is truly just as much yours as it is mine. And thank you to each and every one of you in this room for your investment in me as a physician and as a surgeon. It has truly been an incredibly stimulating and rewarding experience. I cannot wait to dedicate my career to breast surgical oncology and look forward to having a very meaningful impact on my patients. And I hope to continue to represent UVA surgery in a very positive light. Thank you, and I'm happy to take any questions and open the floor to comments.
Great talk. We did tape it, right? Because, one of the things we're supposed to do is teach the teacher, right? And, sometimes I think we're not so good at that, really. And this is a great overview of this. And I know it's effective because you have won, we outlined the national award you've won, but you've basically won every teaching award that exists at the University of Virginia. And I know that because I've written multiple letters for you about these things. And so it works. So I think the proof is in the pudding. So thank you. My question to you is, I do think back on some of the teachers that I've known. One in particular, Don Gould, who taught ancient Greece and ancient Rome, and he was very engaging, very funny, really liked going to his class. It was really, really a good experience. You learned too, but it was really. So one day I'm in his office and I'm looking at his notes, and I thought it was all spontaneous, and he was spontaneous. He has in his notes the jokes that he's going to tell. And yet I had no clue that, right? It all felt very spontaneous and very new and very fresh. One of the challenges that I find is I say the same thing over and over and over and over again. And it is sometimes hard to keep that freshness to it. How do you keep that freshness so that the student is getting the same work that they had, that 7th grader had?
That is a truly phenomenal question. And I think it's so easy to, especially once you're so advanced in your career as an attending, you of course know the information so well, and keeping that light is important. For me, the thing that I found most rewarding is seeing a struggling student, that light bulb go off. And once that light bulb go off, it's so intrinsically gratifying to me that I get more invested in that student or in that junior resident when working, starting even over the summer. When you see them progress from closing an incision to closing the incision by themselves to tying knots, I mean, it's just so rewarding to me to see that progression. But that's the fuel that keeps me going. They're super appreciative, because I remember when I was a medical student, they were select people who were super invested in me. And, that was so meaningful to my career. And how cool would it be for you or for us to be that person in their life?
That was awesome. And I think first, I just want to say it's American Society of Breast Surgery today. So I think a lot of my colleagues who would love to be here and support you are unfortunately out at that conference. But we are so thrilled that you're going into this field, and it's a perfect combination of your love of education, because as you said, it's so important how we educate our patients, and it's clear that you have a passion for both. And you spoke a little bit about the teaching of the patient, but almost similar to what Charlie was saying, it's the same thing clinic, right? We're repeating ourselves a lot. And I think we try really hard to connect with each patient at a different level. And I think that that's one of the things I find most challenging as we get busier and busier and have either fewer visits with our patients or shorter visits. How do we get to know our patient quick enough to direct that conversation to the right level? And how do we keep interested and engaged?
Yeah, that's also a phenomenal question. And you bring up a really important point. Having reviewed the literature, and I think also some work that you have done, there are many studies and one large trial called the I Can Decide trial, which is looking at using decision aids, not only in the clinic, but now potentially using those decision aids and using them at home. So the AI program can start to learn the patient's preferences for mastectomy versus lumpectomy, their need or desire to avoid radiation or not, and what they find personally meaningful, as long as their oncologic outcomes can be equivalent. So I think using that data and bringing some of that platform to the pre-clinic visit can better inform our discussions with the patients while minimizing the time.
Thank you.
Yeah.
Rick, I echo, it was a beautiful talk and inspiring. I had a couple questions. One is, I think traditionally we pursue teaching in kind of a Socratic method, whereas what you're describing with your 5 pillars is more didactic. And I'm curious about how you integrate those. The other question, which is kind of related, is it seems like what you're doing each time is writing all these things out. And one could argue that it might be simpler just to print that out, but I'm guessing you find benefit in working it out in real time with them. But what are your thoughts?
Yeah, that's a great question. To answer your first one first, I think yes, it's definitely exhausting writing it all out every time, for sure. But I think one thing that is nice about writing it out is it allows for it to be a dialogue with the student. And what typically happens is you're having this dialogue with a student, and then the residents on your team want to join. I remember when I was pretty much every year, when I heard the attending speaking with the intern or the attending speaking to the med student, I was like, can I join? I want to learn something too, because you can always learn at least one additional piece of information, even when you pretty much grasp a concept. You can always learn something new, or the way of thinking about something slightly different. To go back to your question though, I think when we, by rewriting it out each time, it really allows for a nice dialogue where it allows for dialogue, but also allows you to interpret where the gaps are. And like I said, sometimes the gaps in knowledge are truly the most fundamental, the most basic principles that have such this profound impact on why do we do that. And I think writing it out really allows it to be this nice exchange. Dr. Sutton.
Rick, excellent talk. Sort of related to Dr. Slima's talk, I think education to me is a two-way street. You talked a lot about how you're investing in the students, the residents, but in your mind, what are your basic expectations of what they have to, come to the table with, right? Again, do you tell them tell me about your expectations for how they should be contributing to their learning?
Totally. I think that's a really very, very, very important point. So there's a couple of things I can say at that. So I have very high expectations for the students on my team, but also want to invest tremendously in them. From day one, what I usually talk to them is I start the conversation. I start by giving them the information because that gives them some path to start looking up information at home. And I say, all right, we ended the conversation here. Tonight or this week, look up these topics, the diagnostic workup for this thyroid nodule or this pancreatic head mass. And tomorrow, then we'll talk about it in a more organized way. Because one, that allows them to bring knowledge to the table and help dictate the dialogue. So we can actually have a dialogue rather than it being just a unilateral lecture, if you will. The dialogue really allows for that knowledge to be ingrained, I think. Dr. McGarren.
That's awesome. Thank you so much for sharing further and providing. To follow up on both those comments, Dr. Sun and Dr. Slingloff, when I was a clerkship director and was giving the students orientation, we were joining, one of the things that I tried to stress with them was that they were active participants in this whole process. And rather than me using the word teach, although we all use it, of course, what I told them was, we're going to facilitate your learning. And so that my hope was that would at least engage them in the process. And what I told them as well is that, or share with them, is that from this point forward, you're responsible for your own learning, for your own education. So it's a dynamic thing. I mean, you've expressed that in all you did that with all those things you did with the kids in the school, and you were facilitating their learning, but trying to at least impart that there's a responsibility for their own learning from here on in. In terms of what they're going to do, and
I think to incorporate kind of all of the comments and questions, and again, to hone in what you were talking about, I think, again, by starting that conversation, they now know what to start focusing on. I think so many medical students, and even like when you start intern year, you're so excited. Sometimes you don't know what to focus on. There's so many textbooks, there's so many anatomy books, there's so many atlases. Like, where do I start? Where can I, and having guidance from us in the room really allows to start that educational trajectory. Dr. Holland.
Rick, thank you. You've been just such a great chief this year, and just watching you rally your teams, it's a joy to be on the team with you as the chief resident on Blue, and just watching you teach in the OR and just being around that is amazing. And the evaluations that you put in for the students, I mean, it shows a true commitment to your teaching. My question to you is, if it's great teaching students who are excited, or it's great teaching learners who are as passionate about the field as you are, but how do you teach learners who may not be as engaged, or they have various other things that they have to focus on, like going home and studying for their shelf, and you have this great case coming up. Like, how do you engage them and get them as passionate as you are about the field?
Totally. I think that's an amazing question, because so many students don't go into surgery. Every year we have between 10 and 20 or so students that apply into surgery. So let's just say 10. So we're dealing with a lot of students who don't end up going into surgery. So like you're saying, how do we engage those, or students who maybe aren't as interested? When that does come up, what I frequently find, or what I frequently do for that, is tell them that a lot of the times on their shelf will say, oh, the people that took the shelf last month said there was none of the answers were go to surgery. And I tell them that the 90% of general surgery is all medicine with surgery. It's knowing all of medicine, the workup, the aftercare, as well as the operative intervention. And I think when I'm able to frame it to them that way, like, oh wow, when I'm on red, yeah, maybe I don't need to know how to dissect a longly recurrent laryngeal nerve, but I need to know, if I'm an internal medicine doc, how to work up a thyroid nodule, how to work up a breast mass. What if my patient presents with rising LFTs? And I think when you present it that way, like, this is all medicine, it's all fascinating. And I think that really pulls in and allows them to understand, oh, that's when I'm learning this, even if I'm not going to be the next colorectal surgeon. Dr. Tache.
So Rick, I also echo everybody's comment as how great of a chief resident you have been. And one of the things that touched me the most about your talk is talking about education to the patients. I also find it that one of the biggest gaps that we have in medical care is how big is the gap between the knowledge that the patients have and the knowledge that the providers have, and how difficult it is to bridge that gap. And our requirements, our metrics actually really underestimate how much time it is required to really educate a patient, and how important it is to establish a good relationship. And I wanted to hear your opinion as to the impact, for instance, that a language barrier has in terms of educating patients, and how you would go about it.
Yeah, that's a really phenomenal question. I mean, as you know, I speak Spanish, and even today, rounding on one of our Spanish speaking only patient and family on our team, even speaking Spanish, it definitely takes an extra couple minutes. When I speak and interview patients in clinic and speak with them about their what the next steps will be in their surgical care and postoperative care, it takes a lot of time. Much more than the 15 minutes that's dedicated to, 15, 20 minutes that's dedicated to an initial visit. I've thought about this actually a lot in thinking about my future career and how, what if anything, now especially that pathology results and ultrasound results and lab results are given to patients prior to clinic, is there anything that can be done from an education perspective that can be done in the pre-clinic setting prior to that initial consultation visit with the surgeon? And I haven't found an exact answer yet, but it has got me stimulated on thinking about things such as when I answered Dr. Dango's question about the iCan Decide, web-based tool that allows to see, it presents information and then gathers your perspective. How symptomatic is this hernia or this paraesophageal and so forth, and then can really dictate, do you want surgery? Do you need surgery? What the next steps look like. It's something I'm really interested in. I appreciate your thoughtful comment.
Well, Rick, thank you so much for a wonderful talk. You obviously have a passion, and the fact that you've been recognized with pretty much every teaching award here at UVA and nationally, that just shows how much you invested in our students and our residents. We're very proud of you. Parents should be very proud of you. I wish I had a chief resident or when I was a medical student or a resident like you. More just like the grunt at me and stuff. But I think, going forward, I think you're gonna make us proud, not only at MD Anderson, but when you become an attending, I think your patients, hopefully they'll understand and recognize how lucky they are to have someone that cares so much about them, that wants them to learn as much as you want for the students. So thank you so
I
much.
appreciate that a lot. Thank you, everyone. Thanks.
Thank you.